Hey everybody, welcome back to the ECG channel here with Reed. Today we're going to go over beta blockers, and this is our second class of antiarrhythmics, class 2, which are our beta blockers. And beta blockers, as their name suggests, block beta receptors, and specifically beta adrenergic receptors. And beta adrenergic receptors are receptors that are stimulated by our sympathetics. And so these receptors are very excitatory. And so, as you can imagine, by blocking these receptors, these beta adrenergic receptors, we can decrease our cardiac excitability. And so what does that affect? How does that affect the heart? Well, we have here, if I look at my heart in the upper right hand corner, we've got our nodes, our SA node and our AV node. And both of these nodes are innervated by our sympathetic nervous system, right? So these receive sympathetic fibers. And so by blocking the beta receptors on our SA and AV node, by blocking these, so if we block these fibers, what is that going to produce? Well, that is going to decrease the rate of conduction by our pacemaker cells. And so our pacemaker potential is down here in the bottom right hand corner. And so we know that, our phase 4 is this slow leaking channel that is what causes the upstroke of our action potential. And so what we can actually do, what will change when we beta blockade our pacemaker potentials, phase 4 mostly will get depressed. And so what we'll notice is phase 4 will become less sloped upward, and then it'll take longer for that upstroke that is occurring due to meeting our threshold potential. If you don't understand threshold potential so much, you can go check out one of my previous videos. And so we prolong phase 4. And so what is that going to do? That is going to decrease the rate, okay? So beta blockers 1 will decrease our heart rate by blocking, conduction in the sinus node. It can also decrease, my AV node ability to propagate that signal down. And so beta blockers in that case can be really helpful in arrhythmias that utilize or that are essentially supraventricular or above the AV node, because the AV node conducts signal. And so if we block AV node, we can actually impact those rhythms. And so what can we use these for? So 1, we can use these for rate control for atrial tachyarrhythmias, such as AFib or aflutter. Remember, in those cases, the atria is sending a lot of signals to this AV node, and the AV node is conducting them down. And sometimes, if it's happening too fast, we need to slow the AV node down. We can give a beta blocker. We can also use beta blockers to decrease our cardiac excitability. And so what beta blockers do is they can actually decrease the amount of calcium in the cell. And so they can actually decrease what we would call as inotropy, which is the squeeze portion. And so what you're doing by decreasing the strength of the squeeze, by decreasing the excitability of these cells, which is ultimately going to decrease the amount of intracellular calcium, which we know that calcium is what is going to activate the fibers that are contractile in nature inside these cells. And so by doing that, you can actually decrease the oxygen demand of the heart by letting it work less hard. And so by decreasing oxygen demand, people that have ischemic heart disease, coronary artery disease, this is going to be really helpful to keep their heart from going into these ischemic changes. So we said we've got rate control of atrial tachyarrhythmias, but we can also have rhythm control of atrial and ventricular arrhythmias, mostly the tachyarrhythmias. And this is because we are suppressing the excitability of cells. And so if you have premature contractions or if you have reentry pathways, you're decreasing the heart's ability to excite these cells that might be a little bit more prone to firing off early. So what are some examples of beta blockers? Well, this is a very complex topic, and I'm not going to dive incredibly deep into all the different types of beta blockers, but you've got all sorts of beta receptors. And so some of the beta blockers are non-selective beta blockers, which means they block beta 1 and beta 2. Examples of these would be carvedilol, propranolol, and nadolol. And then you've got the selective for beta 1, and those might include drugs like atenolol, metoprolol, esmolol, or bisoprolol. Notice that all these drugs, these are the LOL drugs. So ultimately what I want you to think about with beta blockers is they really block sympathetic innervation to the heart. Areas that receive directly fibers from sympathetic nerves are going to be our SA and our AV node. However, these beta blockers do block the beta receptors that are actually on the cardiac myocytes, and so they can decrease the excitability of all cardiac cells. However, they do predominantly affect these pacemaker cells, and so they can decrease your heart rate. So, hope this helps, and have a great day.